Okay guys, welcome back to our channel. Today we're going to talk about something a little bit different. I know we've been talking about teeth and extractions and implants. This is going to be a pathology case actually, and believe it or not, we see a lot of pathology in our practices. What is pathology? Pathology is basically something that is abnormal. And I'll show you this case. This is a 40-year-old gentleman who went to see his dentist. He had a bad tooth here. You can see it right there. And he ended up getting a root canal. And what a root canal is, they actually took the nerve out because the tooth has decay. They took the nerve out, which is, you see it as a white line, and they fill the canal of the root with this material here, which is this white area right there. So that's what a root canal is. Well, the tooth kind of continued. It had a little dark spot. It had a little dark spot on the bottom of the tooth, and I'll show it to you here. This area, and this area kept growing and growing and growing, and the dentist who was seeing this patient kind of felt like, wow, you know, something is abnormal. We got rid of the infection, but you have this thing growing in there. The patient did complain that he had swelling that comes and goes, and pus drains out of the area. And so we got this gentleman back in our office, and we took a 3D scan. And this is what the scan looks like. We have these scans in our office, and as you can see, there's something in this area that's eating away the bone, and it's expanding. I hope you guys can appreciate the hole inside the bone, and you can see kind of the root of the tooth is right there. All right, so what are we looking at here? What we're looking at is basically these, what we call dental cysts. This area right there, it's a dental cyst, and these cysts, they usually happen from dead teeth. And sometimes you get a root canal and these cysts disappear, but sometimes they keep growing. And I think this is what happened with this gentleman. However, you never know what this is, so we have to go in there and do a biopsy. The other thing that I want you to notice on this X-ray three-dimensional image, you see this. This is what we call the mental foramen. There's a nerve here that comes out of here, and it gives sensation. It goes this way and this way and this way, and it gives sensation to the lower lip and chin area here. So it's very important to keep in mind the anatomy in this area, because we're gonna go after the cyst, but you don't want to damage the nerve here. So you need somebody with experience dealing with these things. Here's another two-dimensional view of this area. Again, you could see this is a cross section, and this is the lower tooth here. Here's the upper tooth here. And as you can appreciate, there's all this missing bone here, and there's something expanding, eating away the bone in this area. So I'll show you what this looks like clinically. So this is the surgery. This cyst is under this canine. This is the canine tooth. This is the tooth that we're dealing with, and this cyst is under here. And what we need to do is make an incision in the mucosa, which is this tissue here is called the mucosa. We make an incision here, and we expose this, and we got to keep in mind that there's a nerve right in here that comes out of here, and it gives sensation to this entire area, and it gives sensation to the lower lip and chin. So we have to be super careful when we dissect this out. So I'll show you what this looks like. After you make an incision and you remove all the gum off the bone, you can see the tip of the root right in here in this area, and you can see this lining right in here. There's a lining, and this is the cyst that we're talking about. The nerve is actually right there. You can barely see it, but there's a nerve here, so you have to dissect this around it very carefully. Otherwise, if you damage this nerve, you'll be permanently numb in this whole area here. And we actually take this lining and we remove it. Here's another picture of the lining. It is right there. So we scoop this lining out, right there. That's the lining right there. And we submit this lining to the oral pathologist. We use the University of Texas at Houston. We use their oral pathology department. It is really the only oral pathology outfit in the Houston area. And then obviously they're all professors. They're excellent at this kind of thing. And they basically, we submit the specimen to them, and they tell us what this is. This could be a number of things, probably 10 things. Some of them are aggressive, some of them are not aggressive. We need to know what this is. If it's an aggressive lesion, we need more surgery. We need to do more surgery. This happened to be a non-aggressive lesion. And then what I do, and that's kind of what you have left behind. You have this hole in the bone and the root sticking through there. And so what we want to do is reconstruct this area. You don't really have to reconstruct it like I did it here, but I decided to do that, and I felt like it was in the best interest of this patient. And this is how we did it. We actually filled this hole back with human cadaver bone. We filled the cavity. We soak this is human cadaver bone. We pack it in there, and on top of this, we put platelet-rich fibrin. If you wanna see how we harvest this platelet-rich fibrin, I'll put a link so you guys could see. This platelet-rich fibrin really helps with soft tissue healing. I find it's extremely helpful, and I'll show you how this case healed. And we suture everything together. And believe it or not, people have a little bit of swelling of the lower lip for about 3 days, but this is not a very painful recovery. Actually, people do extremely well from these. And I usually will see the patient back in 2 weeks, and this is what it looks like 2 weeks later. You'll see a little bit of scarring right in here. There's a little bit of scarring. This usually smooths out, and I'll show you a picture of this same exact area in 6 months. And this is what it looks like 6 months later. As you can tell, it looks beautiful. The scar has disappeared and everything is healed up. And then we actually get a 3D scan just to make sure that the grafting did what it's supposed to do. And this is what it looks like. As you can tell, the darkness disappeared, and it's starting to remineralize. The graft that we put in there, usually initially for the first 6 months, looks a little dark because it hasn't mineralized fully. Because you got to remember, the cells kind of grow into the graft all the way to the center. So the center of the lesion is the last area to kind of mineralize. And I'll show you. You can see it really well on the 3-dimensional X-ray. Here's a 2D X-ray, and you can see. And I'll show you before and after, but you can see how this area is starting to mineralize, and it looks good. There's no further infection, and we really don't even need to address this root canal. I think the root canal is done well. It's just the cyst was in there, and it was growing, and it will continue to grow until you take it out. And here's a 3-dimensional view. Again, you can see that the hole's getting smaller. This area in the center, and if I bring this patient back in a year, and I will do that. This is a recent, I don't have a year follow-up, but I will bring this patient back in a year, take it. This should smooth out, and it should start looking just like this side. So this is healing well, and this hole will get smaller and smaller and smaller as the time progresses. What this ended up being is what we call apical periodontal cysts. This is exactly, these cysts that happen around dead teeth, and sometimes they grow. Most of the time, once you do a root canal, it goes away, but almost always they continue on growing, and you just have to treat them like we just did. So that's kind of, if you wanted to wonder. This is what we get back from the pathology. Now, some of these cysts are aggressive, and what I mean by that, so this is a non-aggressive cyst, but some of them are aggressive. There's like 3 or 4 of them are aggressive, and they have high recurrence rate. And one of the reasons why I graft these lesions is because if this, for example, comes back as one of these aggressive cysts that come back all the time, it's easier to see recurrent lesions in grafted bone than if you were not to graft it. So you don't have to graft this, but the graft, first of all, makes the bone heal quicker, and if you have any recurrences in these lesions, you can see them a lot earlier, and you can address those if you have one of those cysts that do come back. Now, this cyst happened to be not not an aggressive cyst, and we really don't need to do anything. We just follow the patient, make sure that he doesn't have any recurrences. Here's before and after. You can appreciate it. This is on the day, this is right before surgery. You can see all that darkness here, and 6 months later, it's healing well. And then the endodontist will have to kind of keep an eye on this tooth here over the next 6 or 12 months, just to make sure that there's no issues with it, and this darkness doesn't come back. If it comes back, then we need to redo the root canal for him, but we don't do any of that work here. And here is a before or after on the 3D. You can appreciate how big this is, and you can see the holes getting smaller. And the reason why is because native bone cells heal, and they heal very, very slowly. And it's probably in 12 months, this area will look like this side here. Anyway, I hope you guys learned something. I hope this is helpful. This is kind of how we manage these lesions. And I hope you understand why I decided to graft these. Anyway, if you have any questions, please link them below, and let me know if you want me to do anything special or talk about anything. We see a lot of stuff here in our oral surgery practices. We do anything from cosmetics, implants, extractions, trauma. So you'll get to see a lot of that. And as I have more and more interesting cases and more pictures, I'll put them on there for you. Anyway, hope all's well and good luck.